datang di dalam acara kuliah umum Visiting Professor bersama Profesor Bert Molewijk dari Amsterdam Medical Center. Jadi beliau adalah Visiting Professor dari Bioethics yang ada di Amsterdam, terutama ahlian beliau adalah Clinical Ethics Support. Dan pada siang hari ini kita akan melakukan salah satu rangkaian acara dari Bioethics Week, yaitu kuliah umum terkait pentingnya layanan etika klinis, layanan dukungan etika klinis bagi para profesi kesehatan di rumah sakit. Di Prof. Bert nanti akan berbagi sudut pandang dan juga pengalaman, terutama dari pengalaman yang ada di Belanda, bagaimana layanan dukungan etika klinis yang disediakan untuk para tenaga kesehatan akan secara langsung berdampak positif pada kualitas pelayanan. Jadi selain berfungsi memberikan dampingan dan juga membantu para profesi kesehatan mengelola permasalahan dilema etika klinis, tapi juga akan ada data-data hasil penelitian dan juga bukti bahwa pada saat tenaga profesi kesehatan didukung pada saat mengelola permasalahan dilema etika klinis, maka itu akan berdampak positif pada luaran dan kualitas layanan. Sehingga itu juga memberikan dampak baik bagi pasien dan juga bagi institusi layanan kesehatan. Sehingga inilah mengapa salah satu tema yang kami angkat untuk mengadvokasi bahwa suatu bentuk program dukungan layanan etika klinis bagi tenaga profesional kesehatan adalah sebetulnya sebuah hal yang fundamental mendasar di rumah sakit atau di fasilitas layanan kesehatan. Kami ucapkan selamat datang kepada Bapak dan Ibu yang sudah hadir secara online dan juga secara luring di sini di Gedung Tahir lantai 8 FKKMK. Pada kesempatan siang hari ini, nanti kita akan mendengarkan kuliah dari Prof. Bert dan juga bisa berdiskusi secara interaktif. Dan ini mungkin memperkenalkan bagi Bapak dan Ibu yang baru bisa mengikuti acara bioetik pada hari ini, jadi mungkin belum mengenal beliau. Kalau Bapak dan Ibu yang sudah mengikuti kegiatan Bioethics Week dari kemarin hari Jumat, mungkin sudah sedikit banyak mengetahui latar belakang beliau, tapi mungkin kita sedikit saja mengulang CV keahlian Prof. Bert. Beliau adalah profesor full-time di departemen di AMC, yaitu Ethics, Law, and Medical Humanities, dan beliau adalah kepala sectionnya atau kepala divisi untuk Ethics Support and Research Integrity, kemudian juga co-founder dan koordinator untuk European Clinical Ethics Network, dan juga General Secretary dalam Executive Board European Association of Centers for Medical Ethics. Dan beliau juga banyak publikasi dan penelitian dan juga area kerjanya bidang Clinical Ethics Consultation, Medical Ethics, Bioethics, kemudian dalam bidang penelitian empirical ethics, empirical research, juga dalam pendidikan, ethics education, dan beberapa topik spesifik yaitu di tema-tema gender dysphoria, transgender person, transsexualism, pediatric onkologi, dan juga COVID-19. Jadi pengalaman dan kiprah beliau di bidang clinical ethics support terutama sudah sangat banyak sekali, sehingga nanti harapannya kita bisa saling berdiskusi, bertukar pendapat, dan bertukar perspektif bersama Bapak dan Ibu, baik itu secara online dan juga secara luring. Jadi nanti kita akan berikan kesempatan kepada Prof. Bert untuk menyampaikan paparannya, dan Bapak dan Ibu jangan khawatir, nanti pada saat berpartisipasi kita akan berusaha memfasilitasi dalam bahasa Indonesia dan dalam bahasa Inggris, sehingga yang kami sangat harapkan adalah partisipasi aktif dan komunikasi diskusi, walaupun dalam bahasa Indonesia tidak mengapa, nanti akan kita coba fasilitasi. Semoga masalah bahasa tidak menjadi kendala untuk bertukar pikiran dan bertukar pendapat. Mungkin langsung saja kita sapa Prof. Bert pada siang hari ini. Good afternoon, Prof. Bert.
Good afternoon. Selamat siang.
Selamat siang ya, Prof. Bert sudah belajar beberapa kata-kata bahasa Indonesia dalam 3-4 hari ini. So,
I agree.
Yeah.
No,
Yeah. So, Prof. Bert, this morning you learned about selamat pagi, and now we changed into selamat siang. Yes,
yeah.
siang.
So because of the
Yes, so good pronunciation already. Yeah. So, Prof. Bert, I was just introducing you to our participant that we also invited for this afternoon session, our clinician, health professionals from our networks of academic hospitals, so mainly from Sarjito and then from the UGM Academic Hospital and all other hospital that is in our networking. So maybe I cannot mention one by one, but we have some audience in the online, and we have some of them present here, our practitioners and our health professionals. So, but then we also still have our master students of bioethics. So yeah, it's quite diverse as well. But mainly you will be discussing and sharing your experiences and expertise about how clinical ethics support is important in the hospital and how it can benefit both the health professionals and the institution, right? Okay, so
Thanks a lot.
without further ado, time's yours, Prof. Bert. So yeah, again, we will bridge the communication. So if there's anything that you feel like you need to make it more emphasis, then let me know, and then maybe I will help the participant to understand the highlight. And well, from the participant, we are going to invite also in Bahasa. So hopefully language should not be a barrier. Okay, time's yours.
Thanks a lot, Etika. And is the lecture or the interactive lecture also recorded for doctors, nurses that could not attend?
Yes, we are recording it, and we will be it will be available later after we collect everything and make sure that it's properly accessible.
Thank you. Yeah. Well, dear, thank you. Thanks a lot for the hospitality of the Center for Bioethics and Medical Humanities, that they invited me to come over all the way from Amsterdam to Yogyakarta, or to Jogja. I'm really pleased. For some of you, I already know from earlier lectures from myself this morning, but I see some new people as well. So a warm welcome to you as a new guest, and also online, the people that I not see, but you can see me or us. Also a warm welcome for you online. As Dr. Wiek already said, it is an interactive lecture. I think the lecture becomes more fun and more useful for you if you can apply it to your context. Especially today, it's the clinical context, the healthcare, the hospital, for example. So again, I want to stress that now and then we will stop, and I will stop talking, and I will give you possibilities to ask questions with respect to the role of ethics and ethics support. I already got a very kind introduction about my CV, but I just want to stress that I started my working career in clinical practice as a nurse, a mental health care nurse. So I have been a healthcare professional for 6 years, and then I went to the university to study ethics. So if I usually introduce myself in 3 words as a profession, then I usually say I'm an ethicist in the first place. I'm an ethics trainer, not a teacher, more an ethics trainer, and I'm a social scientist. So today I will give you some examples from my work as a clinical ethicist in the hospital in Amsterdam. I'll tell about it more, but I also will show you some research. My group, it's not only myself, of course, my group have been doing clinical ethics research for 20 years. And I will touch upon the more pragmatic question: is it useful to spend time on ethics? Is it useful in the busy hospital where there's no time to talk together or to reflect together because we're all busy and there is a shortage of time and a shortage of staff? Can it still be useful to have ethics support or have ethical deliberation? So that's my voice as a social scientist. I like to do clinical ethics together with the people in the hospital, but I also like to be like a manager. If we spend time for doing ethics, for example, case discussions, then I want better care. And therefore, the title of today is Dealing with Moral Challenges in Clinical Practice, Improving Quality of Care, the cooperation among professionals, but also with patients and family, and also the improving of the self-care. So to help the professionals to deal with their moral stress by the means of clinical ethics support. That will be my focus of today. The slides are not only the interactive lecture, the video recording, but also the slides are available for those who want. And of course, in 20 years of research, there's a lot of data, so I will only present a part of it. But if you are interested, please contact me so I can send specific papers or research results. This will be the outline of the presentation of today together with you. And we have another 1 hour and 40 minutes. So I think there are 35 slides. And we will see. It's not my purpose to rush through all the slides. My purpose is to address your questions or concerns in how you work with clinical ethics. So this is, I will start with something personal. Where is the ethics in the clinic? Then I will talk about ethics support as a specific discipline. I'm a professor in clinical ethics support, and that's a special discipline, I think. I will tell you a little bit about a specific way of ethics support, moral case variation, and then a little bit about evidence, the evidence of the usefulness of ethics support. So here's the manager. In the Netherlands, I like to sell ethics. What I mean with this, in the Netherlands, I go to several hospitals in the Netherlands, and nursery care, psychiatry, so different kind of healthcare. And I talk with the management, and I try to convince them that it's useful and effective to pay attention to ethics. And then they say, well, Bert, we don't have time for this. It's too busy. So one of my missions in the Netherlands is to focus, explain what the positive outcomes is of, for example, case deliberation, or more in general, ethics support. So one of the reasons why I like ethics support is that ethics is always about something that matters to us. So ethics, I think ethics is never dull, never superficial or dull, because ethics is always about core values, norms, dilemmas, our virtues. What is a good doctor? What does it mean to be a good nurse or a good manager, or even a good cleaner in the room? So for me, ethics is always about something important in life, usually serious, but also important. If you do ethics, so I think ethics is there everywhere. There's even ethics in this room. What you consider respect for me as a teacher is already based on some norms about what respect for a teacher means. So there is already ethics, even now in this room. But usually, if we want to talk about ethics together or reflect about ethics together, usually there's little time. So if we do, that's too quick. If we do ethics board together, for example, an ethics committee or a case discussion, an ethics case discussion, then it's one of the few moments in our daily work, which I experience also as a nurse, where there is a little bit time to talk about each other moral challenges or stress. So therefore, I like clinical ethics support because it's one of the rare moments that we have time for each other. Usually we are with our work, but in ethics support, we sit still, usually in the table, and then we talk to each other. Another way is that, this is also for me very personal. I believe, for me, ethics is not a moral police. For me, ethics is not saying to the people in the room or in the hospital, you should behave like this, and this is wrong, and this is good. So that's normative ethics, or even prescriptive ethics. For me, ethics is a dialogue in which we can be critical to each other. And I know in the Dutch culture, and maybe in the Indonesian culture, to be critical is usually, it's difficult to be critical, or it's difficult to have a different opinion in the first place. So what I like about why I started to fell in love with ethics is if you do it in a safe and respectful way, ethics reflection about cases. Then it's the dialogue version, so not the debate, but the dialogue version can help us to be critical and even sometimes disagree in a respectful and constructive way. I think that in practice, in healthcare, this is quite seldom. It's very difficult to be respectful to my boss and at the same time try to share my opinion. So for me, and I'm really sincere here, for me, ethics is a way of a free moral space in which we are kind to each other, so no fighting, no conflicts, but in which we can ask critical questions. A little bit, I'm not sure you know the philosopher Socrates, that's my favorite philosopher. Socrates was really good in asking questions about how do you know what is morally good? How do you know what is a morally good doctor? How do you know what is a morally good nurse or husband or father? So he was really good in asking critical questions. I don't like criticism. I don't like conflicts, but I like ethics because there it can be in a safe environment. If you do ethics in a good way. If you do ethics in the hospital in my opinion, bad way, and you say, nurse, you are morally wrong. You did a moral failure. It's not good what you did. Then it's not safe. This is not constructive. So one of my tasks as an ethicist in the hospital is to let people be on the same table together without offending each other and without also, harming the other. That's important for me. So often is this way of dealing with each other, it creates liberation. I can say what I think. I don't have to be careful about what you think. I can say what I think. And at the same time, I feel connected with the group. So I can stay connected even if we have different opinions. Well, that's my personal story. And then what I like, I'm also a manager myself. I'm a social scientist. What I like about ethics support is sometimes if you sit together as a team or in an ethics committee and you talk about a very complex case, then you can use the insights to actually improve practice. So this sentence, although it's between brackets, for me, this sentence is very important. It sounds paradoxical. This sentence is important. Some people think, Bert, you are an ethicist. You try to sell ethics. So you want that everybody is doing ethics. Okay, I think it's good to do ethics. But in the end, I think if we have ethics discussions in a room, we try to learn from the lessons in the room. And I'm talking as a social scientist. We should talk about the lessons. For example, maybe we should change the policy in this world to deal with this issue better in the future. So what I like about doing ethics support is not only the ethics reflection itself, it's not the only goal, but also try to improve practice. One simple suggestion or example, I've been working as an ethicist in a psychiatric hospital. And there we had the board of the directors of the hospital said to our team of ethicists, there are many moral questions about the use of coercion in psychiatry. And we want to improve the practice. We want to use less coercion towards patients. And if we use coercions, we want to do it in a better way. So what we did is we organized 10 sessions, case discussions about coercion and moral questions. For example, the question, when is it allowed to put a psychiatric patient with force in isolation room? That's a difficult question. So, an example, so what we did, we planned 10 sessions of 2 hours in a year. So every month, one session. But then later, we analyzed the insights from the 10 case discussions. So 10 sessions in 1 year. There was a recording of the session, like we are recording the lecture today. And then we, as researchers, analyzed the arguments for coercion or against coercion. And then we made new policy to improve the practice. Do you know what I mean? So ethics is not only talking about and thinking about more issues. For me, ethics support is also trying to improve practice. Sometimes I become a little bit cynical because there are ethics committees, for example, or there are case discussions, and they have fantastic case discussions, fantastic committee meetings, but the practice doesn't change. The practice doesn't improve. So, well, that's a long introduction. Sorry for that, but that's maybe then you understand how I see ethics, not as a way to connect with each other and to improve practice. Okay, let's start with the ethics. Some people say to me, yeah, Bert, where is the ethics? I don't know. Where can we see the ethics? Can you see the ethics? Well, here you have this is an observation from multidisciplinary treatment meetings. Do you know how this is called in Indonesia? The meetings where professionals talk about the best treatment for the patient. Is it called MDOs or is it called treatment meetings or? Yeah, that's a guideline, but do you also have team meeting? No, clinical conference. Yeah, thank you. Yeah. So clinical conference. If you attend a clinical conference, then and you say, okay, Bert, as an ethicist, I was observing the clinical conferences, for example, in Amsterdam. And they said, but where is their ethics? I don't know. I don't see ethics. It's, yeah, euthanasia, that's ethics. Abortion, that's ethics. End of life, yeah, that's ethics. Cloning, that's ethics. But many people, many nurses, doctors, cleaners, managers, they see, well, Bert, I never see ethics. I just do my work. I follow the guidelines. So what I did, I observed clinical conferences and I tried to show to the clinical teams, where is the ethics in your work? Well, the clinical conferences, they talked about, blah, blah, blah. Okay. And they talked about what is a good treatment for patient X, patient I, patient Z. And then I hear there are different reasonings about how they determined what a good treatment is. And of course, you recognize, I hope, if you work in healthcare, you have. So some people say, some professionals said in the clinical conference, well, treatment X for patient I is a good treatment because it's based on sound evidence-based knowledge. It's from science. So therefore, this is a good treatment. Another professional, maybe 1 week later said, well, I think it's a good treatment if it's based on the professional guidelines. And me as a nurse or as a psychiatrist or as a surgeon, I follow my guidelines. And then I know what a treatment is. That's a different way. Of course, let me be clear, most professional guidelines are based on evidence-based knowledge. Yeah. Somebody is saying in the team, in the clinical conference, it's a good treatment when it contributes to the health of the patient. Or another argument, it's good treatment if it prevents or decreases the harm or the suffering. Another, so you get, maybe you get the point. There are different ways of defining criteria for a good treatment. Some people say, well, patient autonomy is important, so a good treatment is what if a patient wants it. Another is saying, well, a good treatment if it fits within the life story, not per se the preferences, but it should also fit in the life story of the narrative of the patient. Some say, well, I'm not sure what a good treatment is, but if the process in the clinical conference is okay, and we listen to all the arguments, then we know what is a good treatment. Okay, so here the last one, it's just examples. If the whole team, the clinical conference team, agrees, if there is consensus, then it should be a good treatment. So in a short moment, the last two, I try to explain to you and to the clinical teams, here there are many different ways of defining what is a good treatment. And there you can already see different ethics reasoning. For example, the reasoning about patient autonomy, or reasoning about decreasing harm, so about the consequences, or the reasoning about it should be evidence-based knowledge, or this could be also following the guidelines. So there are consensus. So here you see that there are different ideas, and then I think sometimes in your clinical conference, this may conflict between each other. And if it conflicts, then you have an ethical question. If the patient and the family patient say treatment X is better because we want it, and the doctor say treatment Z is better because it's in the professional guidelines, then there is an ethical conflict because they have different reasons about how we should determine what is good treatment. So this is just a, I hope, simple and I hope clear example that even if we talk about our profession, like a good treatment, then you have different normative views about what good treatment is. So there's implicit ethics. Remember on the slide, implicit ethics. It's not that clearly that the ethics is here, but you can see, well, they follow different kind of reasoning. Now we go to explicit questions. So this is also from research that we did in Amsterdam. So explicit questions can be, again, from psychiatry. I have been a psychiatric nurse, and I've been working as an ethicist in psychiatry. So some of the examples come from psychiatry, but now I work in the academic hospital in Amsterdam. This is an explicit moral question. What is the right timing to use coercion in care? If a patient starts to become fear or aggressive, should we then early already give the patient medication for calming down? Or should we put the patient early already in the isolation room? Or should we only do this when he's really hitting somebody else? Or so what is the right timing? So this word, the right timing, is the explicit moral question, isn't it? You can be too late with using coercion or with offering a treatment. You can be too early. That's an explicit question. Should we, so this was a question that I got from the board in the hospital, the management. Should we, this is a normative verb, so explicit moral question, should we cover the high costs for this rare disease? This is also often I think a political question in the government on the national level, I guess also in Indonesia. If a rare disease, so only few people in this hospital or in this country have this disease, and the treatment is very expensive, should we still cover it? Or should we say, like in the Netherlands sometimes, this drug for this kind of cancer is too expensive, we will not cover the insurance? That's really an explicit moral question. Okay, shared decision making. At least in some cultures, shared decision making is important and patient autonomy, but is it also a duty? If a patient doesn't want, in the Netherlands, if a patient doesn't want to be autonomous, should he be or she be autonomous? That's also an explicit question. And now some more, I will not talk too long. Sorry. So some examples. When are we allowed to dismiss a patient who does not want to cooperate in the treatment? You know, all from the textbooks in ethics maybe, lung cancer. You treat somebody with lung cancer, he or she is still smoking, he got a treatment, she got a treatment, she quits the hospital and continue to start smoking. Should we then still continue to offer treatment or not? And now I think there's also ethics in the human resource manager. I'm a team leader of 25 persons in Amsterdam. When should we dismiss a non-functioning employee? So fire. That's also a moral question. It's not only a legal question. And if you know, there's also in education, students, when should you say to the medical doctor students or the nurse students, sorry, we think you are not good enough for becoming a doctor or a nurse? Yeah, of course, you can go to the points of the grades, But sometimes this is I think this is a moral question. Not only because of the grades, but also, for example, because of the attitude of students. This is something from ethics. So this is more ethics in research. I'm a professor. When is it justified that the supervising professor is mentioned as last or second author without doing something in the research? That's also an ethics question. So here we see different ways of doing having ethical questions. Is there another question you know from your practice? Any ethical question that you have been discussing in your work, maybe during the clinical conference or any? Yeah, there's a question. Yeah. Does it work?
Thank you, Prof.
Thank you.
My name is Handoyo. I'm a neurosurgeon.
Surgeon, neurosurgeon?
Yeah, neurosurgeon. Several years ago, we have a case of conjoined twin. You know conjoined twin? Conjoined twin.
Conjoined twin, yeah.
Yeah, in the head. Yeah, so there are two baby girl with the head is conjoined. We have a hard discussion about separate or not separate. Yeah.
Yeah.
It's many
different viewpoints.
Yeah.
Arguments.
Many different points.
Yeah. That's it's not an glad example, but it's a very good example for ethics because that's clearly an ethical dilemma.
Yeah. It's a big dilemma. Yeah.
Yeah. And maybe did you for me, independent of what your team decided, whether to stick together, the two twins, or whether to operate, to split, how did you came to a conclusion? Because that's so difficult in ethics.
Yeah.
Do you want to share this with us?
Yeah.
Yeah, okay.
Yeah, we have several discussion and difficult consensus about that. But we invite a professor from US to give some advice about the spirit of this conjoint, and after many discussion and information that we have, the team with the multidisciplinary team, I think with the bioethics team too, we decide to not spread. Yeah, and up to now the baby maybe 8 years, and they still alive, and their activity they can stand, walking, and activity.
So they are now 8 years old?
Yeah.
And they are okay, doing well?
Up to now. Yeah.
Sorry?
Up to now, yeah.
Up to now, yeah.
Yeah, up to now. But we have more ethical question. Yeah. How about the future of these girls?
Yeah.
Thank you.
Thank you so much. I'm always happy if people from the audience have examples. So thank you for your and also great that you are here from the clinic. This is I think a very good example of how difficult it can be. As an ethicist, this also sounds a little bit like a true dilemma. And a dilemma, in my understanding, a dilemma is a kind of a moral problem in which there is no ideal or one solution. If you let them stay together, the twins, then there will be some harm or difficulties. If you split them, there will also some risk, I guess, with operation, serious risks, but maybe also serious risk with respect to quality of life. I don't know. I'm not a neurosurgeon. So a dilemma is a situation in which whatever you do, of course, you need deliberation, you need team discussions, and maybe you need experts, neurosurgeon experts, or research experts, or maybe ethicist experts. But in the end, there will always be harm, because there is no simple answer, isn't it? So in my research, now I'm talking as a researcher, as a social scientist, what I learned from healthcare professionals, nurses, doctors, also managers, is when they realized that their situation, this difficult situation, is a dilemma, and that a dilemma means there is always a kind of harm, whatever you do, therefore it's the dilemma, then many professionals were less stressed or less, it was still burdensome, the decision making, but if you realize, well, we and our team are now in a dilemma situation, so whatever we will do, there is some kind of harm. We try to do the best decision, and we try to decrease the amount of harm, but there will always be a little bit harm. This is very important because many healthcare professionals said to me in my research, now I understand what a dilemma is. I know that if the situation is a dilemma, it's not only on my shoulders if I make the difficult decision. So here, I think that, I hope you understand, this is a simple example in which only explaining what a dilemma means helped professionals, and will help professionals, that they don't feel, that they don't have to be guilty maybe for the decision they made, that they do their best to make a very good decision, but that they now know, because it's a dilemma, there will always be some kind of harm. So thank you again for sharing your case, and it would be nice, for example, if we go back in the end, maybe a last question, if it's okay. What would be the most, what was the most important reason for you as a team to say, maybe we should not divide them now, split them, but hold them together? Was there were many arguments, I'm sure, but was there one central argument in this case?
Pertimbangan utamanya dulu itu ya, Dok ya. Kenapa kok akhirnya tetap dipertahankan gitu ya, Dok? Apakah mungkin boleh disampaikan?
Yeah, after any information, we have some image of radiological and many other of the case. All of experts agree that if we separate the baby, we have harm. Yeah, the baby will have the high risk of the maybe morbidity until mortality.
Yeah.
Yeah. So the baby stay in our hospital until several years and before they go to the family.
Yeah. So the twins stayed in the hospital for many years.
Yeah.
Yeah.
3 tahunan ya, Dok ya?
Yeah.
3 tahun.
Yeah.
Jadi tadi kalau boleh di highlight tuh dulu dilemanya adalah memisahkan atau tidak memisahkan, kemudian diputuskan untuk tetap dipertahankan, tidak usah dioperasi, dipisah karena kalau dipisah prosesnya lebih high risk ya, lebih membahayakan, bisa menimbulkan kecacatan yang permanen, berat atau mungkin bahkan kematian saat prosesnya. Jadi dipertahankan dan mereka hidup. Nah, tadi pertanyaan dilemanya sekarang adalah kan mereka itu sudah hidup dengan kondisi seperti itu, tapi dengan masa depannya apakah itu mereka akan menghadapi hidup yang baik gitu ya, Dok ya? Kualitas hidupnya bagaimana itu ya, Dok, concernnya?
Gitulah.
Ya.
Terima kasih.
So, terima kasih Dr. Handoyo sudah rawuh dan so we were also in the discussion. So Dr. Handoyo mentioned that the Sarjito team and also our center, we are in one team. We are involved in the discussion. So the central argument during that time, the main dilemma is whether or not to separate, and then we decide to keep the babies not separated because of the clinical reason that it is going to do more harm, because the separation operation is going to most likely, very likely ends in either morbidity permanent and a very difficult situation, or even death. So that's why we decided that it's best to keep them not separated, because then they still live and able to function despite the different anatomically with other kids. But now the question from physicians are like, what about their quality of life now that they live in a society with different appearance, different anatomically?
Yeah.
And so what about their future as girls, as human, because they are going to be tied together the whole their life. So maybe it's like, maybe like a moral burden, or like a question whether we made the right decision, because then what about their future? Is that the right decision? Because now they have to face the society with that situation, despite they still preserve their life, but like it's another concern now. So I think that's
nice. Thanks a lot for the explanation. So here, as an ethicist, I hear different ways of reasoning or different arguments. For example, decreasing harm. So like we often do in ethics also, and in medicine and in nursing, is if the harm, for example, even like mortality rate, if the surgery is so dangerous, and we know that the quality of life maybe can be very challenging for the twins, but then you weigh and you say, well, mortality is worse, maybe, not always, but maybe in this case, mortality is worse than a bad quality of life, or a difficult quality of life, or a challenging quality of life. So then we say, okay, if we want to avoid that the twins are going to die in this risky operation, then it's better to continue as twins together. So there, and of course it can. You could also say, we don't have the, for example, we don't have the money to operate. Could also be, the patient and the family. I didn't ask about the family and the parents or the family around, but you could also ask, should we let them have a or not? That's also another reason of deciding. But thanks again for this difficult ethical question. I suggest we continue, and please raise your hand if you have any question or case online. Yeah, perfect.
Question? Do you?
Yeah.
Okay, so.
Oh, this one?
Yeah. The tips and tricks to have a good dialogue, so that the dialogue does not fall into a debate, because so to avoid like become a conflict, like what you mentioned.
Yeah. Wow, this is a very important question. This is from, yeah. So Julie, thank you. I think this is a very important question. So I'm glad I didn't see it because I was busy with I think this is one of the, for me also, a very difficult, now it's not difficult, but it's very important. Also in Amsterdam and in the Netherlands, I don't know the Indonesian culture that well. Part of the reason why I'm here in Indonesia and why I travel internationally is that I want to learn from other cultures about dialogue. Like I said in the beginning, in the first slides, the way I approach ethics is I see ethics as a dialogue. And can I have the question one more time? Or did I do? Yeah. So one thing I will give a short answer, because later I will talk about dialogue, why it's so important. So one tip and trick, and that's an important trick and tip, is if you have an explicit ethics discussion, and now I'm talking to Yuli, then it's good to say, this is not a clinical conference. This is not a decision-making meeting. Let's just try to collect many different voices so we can learn from the different voices. So if you start a meeting like this, if you say, this is not decision-making, this is not a clinical conference, this is not about the boss or the expert making a decision. No, we first try to make a dialogue together. So please, let's see, a dialogue is learning. So this is my definition, description of a dialogue. A dialogue is learning from different voices. And it's not about who has the most, the best answer or the most, that's not a dialogue. So dear group, if I would try to convince the people to make them a dialogue, to have a dialogue said, I know you have decision-making procedures. I know he or she is the boss. I know he or she is the supervising doctor. But now we're having a dialogue just to explore different viewpoints, not about who is right. Please don't try to convince the other who is right. And please, dear professors, don't teach now. So this is a trick. I hope you understand. That was a role play. I hope you understand that if you start like this and you say, you split it, you distinguish it from decision-making powers, you distinguish it a little bit from expertise, medical expertise, and you stress, we don't want to convince the other, we don't want to find the only answer, because in ethics usually that's not only one answer. Please listen to each other. That's a way of, although it's sometimes still difficult, to not fall into the debate. I think a fundamental problem in medicine, and maybe it's not a problem, problem is not a good word, a fundamental challenge is that we as professionals, doctors, nurses, managers, we learn to answer all questions, also moral questions, with our professional expertise. So with, for example, medical information. But I think in medicine or in healthcare, not all questions are solely, for example, medical and evidence-based questions. There are also moral questions. So now I too much maybe and too abstract, but so again, I will not go into this further, but so yes, this is difficult. It's indeed quite harsh. And as a matter of fact, and that's what I usually say to professors and managers, if you are in a debate all the time, and if you don't allow a dialogue or questioning, then people learn less. Because it's fighting, it's about, so dialogue is also a way about learning, I think. So that was a long answer. Thank you for your question. And we could talk a day about this, about dialogue. Now I continue. And again, Dr. Wika, if there are questions. So we talked about this beautiful but difficult case. We talked about my moral questions. Now the question here for you is, okay, so we know now a little bit, most of us agree, there are many different ethical questions or moral challenges in hospital and healthcare. So no question mark, sorry. This should be a... so there are many different ethical questions. How should we now deal with them? Which way should we do ethics? And this question, in which way should we deal with the ethics in a hospital, or in the military service, or in the Dutch prison? I just gave a book about ethics in the Dutch prison. So we do ethics in many, it's not only in healthcare. This is the central question in ethics support, my domain. I'm a professor in ethics support, and my central question is, how should we deal with ethics question in practice? That's the mission of my chair. I'm not I will not start this with you. I will just go to the, so I will not, sorry. So now maybe I will do a little bit. Is there an, in the place where, who of you is working in a hospital? Raise the hands. You are working in hospital, and you? Two persons, and
Yeah.
maybe online. 2 persons work in hospital.
We have 1, 2, 3,
3,
4,
yeah,
5.
5. Okay, thank you. That's 6 even. That's good. I like to work with ethicists and research, but I especially like to work with healthcare professionals because I like practice. So my question to those who work in the hospital is in your, maybe there are different, is it one hospital or are you from different hospitals?
Different hospitals.
Different. Does your hospital where you work, does it has an ethics committee? Yeah?
In Sarjito.
Yes, yes,
So there is an ethics committee?
yes. At the committee.
Okay. And are there also other ways of doing ethics in your hospital, or is it mainly the ethics committee that is taking, is dealing with the ethical issues in your hospital?
Biasanya kalau ada situasi atau konflik permasalahan etik gitu dok, kalau apakah yang kemudian bertanggung jawab untuk mengelola itu dari komite etiknya atau mungkin sudah ada perpanjangan program atau cara mekanisme gitu bahwa selain komite etik di rumah sakit itu terlibat gitu dalam pengelolaan masalah etik.
Yeah, okay. So the ethic committee is a part of a team to deal with the ethic problem in hospital. So like the health professional, nurse, yeah. So we have some committee in our hospital, nurse committee, medical doctor committee, and some of you, yeah. And we discuss about the ethic case with the director to.
With the director of the
Yeah.
hospital?
Yeah.
Yeah.
Director to make a decision about this case.
Oh yeah.
Yeah.
So the ethics committee, because there are many kinds of ethics committee, this ethics committee is with the doctors and the director, and they talk about cases to
Yeah.
to give advice or take decisions.
Yeah.
Or suggest
Yeah,
decisions.
because sometimes director have to make the decision about person that have with the ethic case.
Yeah, yeah. Thanks a lot. And did you ever participate in an ethics committee meeting as a neurosurgeon?
Yeah, sometimes.
Sometimes, yeah.
If the case is related with our
profession.
Yeah.
Was it helpful?
Oh, sometimes.
Sometimes. Thank you. That's enough. Thank you. Because sometimes the question, of course, in ethics support is when does it help an ethics committee? So I like your answer. In the other hospitals, are there ethics committees as well?
I recognize someone from other hospital, so maybe Dr. Aziz would like to answer.
Dr. Aziz?
Yes, sir, in the white shirt.
Good to see you again.
Cannot escape the question. Turns. Take turns. So like the closest first.
Yeah, I think we are not far from what Sarjito has. So, the hospital also have ethics committee, but following the Indonesian regulations, we have at least 2 types of hospital ethics committee. The first is ethical committee under the what's so called as a medical committee. It's a
medical
ethical committee under the medical committee.
Yeah.
So komite di bawah komite medik. And the second types of ethical committee in the hospital is the hospital ethics committee. These 2 different ethics committee has 2 different rules. The ethical committee under the medical committee, they mostly dealing with the professional ethical misconduct or problems or issues.
Oh, okay.
But the hospital ethics committee, they are dealing with more broader ethical issues, like making mission and vision of the hospitals related to what the stakeholder has and other accreditation needs for the hospital ethics committee. So most of the professional work of physicians, the ethical committee who responsible is according to the professionals. So under the medical committee, we have medical ethics committee. We also have nursing ethics committee. We also have other professionals, other health professionals ethics committee.
Yeah.
So these are the differences between the committees.
And thanks a lot. That's really nice, I think, for today that we learn that there can be different ethics committees. And one final question: the health ethics committee, they are you just said they are accreditation of the hospital. Are they also dealing with ethics cases, like single patient cases?
Usually it's not. So
it's more it's more guidelines, policy.
Yes.
Yeah. So that's another kind of ethics. It's important for today. You have clinical cases, like the case from the professor neurosurgeon. Sorry, the name. And then you have that's a patient case. You have guidelines case in that committee, and then you have case under the medical committee, which is more about the management and the human resource, and that's about misconduct.
Yeah.
And also called ethics. Yeah. Thanks a lot. So this is really helpful, and I will come back to this later, that there are different ways of doing ethics. Now we just learned 3 ways. Patient cases, discussing patient cases. Working on guidelines, professional mission statements, and accreditation. That's one other, more abstract, more policy. And then we have the misconduct or integrity or issues. One in Eastern Europe, that's not related to what you just said, so let me be clear. But in Eastern Europe, some people think that ethics is always about misconduct or always about integrity problems. And I think my department, I'm head of a department, it's called Ethics Support and Research Integrity. And in Eastern Europe, it's quite difficult for healthcare professionals, for managers, and for ethicists to see ethics as a dialogue, for something to learn. So if ethics is seen only as misconduct, then what I said in the beginning when I started this lecture, I think it's ethics to pay attention to misconduct. So let me be clear, that's a very good committee. But if all the people in the hospital think there's only this kind of ethics committee, then they have a synonym of ethics, and that's usually moral police. Or I only have to go to the ethics committee if I did something wrong, and then I get sanctions. And I think that's a big problem in healthcare, because then people don't dare to learn, to disagree, to doubt, to be uncertain, because they are afraid that they did the wrong thing and that they are being sanctioned. So I would really suggest all hospital managements to acknowledge the following. You can use doing ethics by developing a vision and mission statement of your hospital. That's one way. We just talked about it briefly. So this is, for example, in the Netherlands, some ethicists and ethics committee and the directors, they make a policy and they say, we are a learning hospital and we want to be the most hospital, the hospital with the largest hospitality in the Netherlands. That's a mission statement. We are for hospitality, or we are for patient autonomy. So this is a way of doing ethics, and that's usually on the abstract level, with abstract values like patient autonomy, hospitality, family-oriented, whatever. Another way of doing ethics in the hospital is a little bit like the ethics committee under the medical committee we just discussed, is, well, ethics, some ethicists should define and enforce norms that people should follow. So here, this is inspirational. We want to be a hospital with hospitality. This is a normative use of ethics. And of course, ethics is normative. So this is about, this is right and this is wrong. And if you go this way, then you're wrong and we will sometimes punish you. So that's the normative ethics. And then you have another one. We have also some hospitals say, well, maybe we should ask the expert or the ethicist, sorry, this is a Dutch word, an ethicist to give the answer. So here you see the ethics is not from a mission statement, the ethics is not from norms or guidelines, but the ethics comes from an ethicist. So if we have an ethics problem, we call the ethicist. So that's the expert approach. Also okay, so I'm not against one of those. Then this is of course my most favorite, because I think we can better learn. Some ethicists say, well, I'm not playing the expert as an ethicist. We are not being dominant with norms, but we are using dialogue as a vehicle for joint learning. I will talk about this later on moral case relation. So moral case relation is, and also Yuli, I answered your question about dialogue. This is really, moral case relation is a way of doing ethics. It's not an ethics committee. It's a way of doing ethics for dialogue, for learning. And sometimes we use ethics reflection and debriefing. So that's another way of ethics for self-care, fostering moral resilience. This is an abstract word maybe, but so here, this is interesting. In Europe, this is really hot. In Europe and in America, in the States, in the USA and in Europe, many people are concerned about the stress of healthcare professionals, the moral stress. I will talk Wednesday in a lecture about moral stress, not today too much, but moral stress is if you as a healthcare professional feel moral stress, because, for example, you're not allowed or not able to do the morally the right thing, and then you get stress. For example, the psychiatrist says to me, Bert, use coercion towards this patient. You have to put the patient in the isolation room. And I say, no, I don't think it's good. I don't think it's for the patient. Then the doctor said, Bert, you have to do this. Then I can get moral stress, moral distress. Moral resilience is that you learn to deal with your moral distress as a professional. So again, this is something that we in Amsterdam do a lot. We do all the 5 things, but this is very, in our approach to ethics, we are mainly focusing on dialogue and learning from each other. And in Europe and the USA, many people are using ethics reflection or debriefing to take better care for healthcare professionals. Why is this the case? After COVID, many healthcare professionals had a kind of burnout, not only because of the workload, that's another chapter, but the people in the COVID time had a moral burnout or moral distress because they were not able to give the right care to the patient they were used to. For example, the famous tragedy is that in many times in occasions, I think here in Asia as well, during COVID, the family was not allowed to be present when the patient was dying. Well, that's really awful. That's really, so many doctors and nurses, they really got stressed and felt guilty and cynical and depressed about the fact that they could not, when patients were dying, that sometimes they could not touch the patients themselves as professional. Sometimes the family could not attend and the patient had to die alone at the intensive care unit. So this is moral stress. And because of the COVID, and because of the in the Netherlands, especially, but in Europe maybe, it's very difficult to get enough nurses and doctors. So they want to take care for the healthcare professionals so that they have enough employees to deliver the care. So this is an important, but again, there are different ways of using ethics in your hospital. And it depends a little bit on what you need or want to do in your hospital. For me, this is, I think those two are very low threshold, good ways to take care for patient care. Okay. Any questions so far about this? I think this is an important slide about how you can do ethics support. Are there any questions, or do you have any additional examples, experiences?
Bapak dan Ibu, silakan di online juga kami persilahkan. Apakah ada komen yang relate tadi seperti sudah dimulai oleh Dr. Handoyo tadi terkait contoh moral question atau moral. So yeah, I would go back to if there's no other question.
Or online, if they're online,
apakah
ada
Bapak
online?
dan Ibu online? Ada, tidak ada. Bapak dan Ibu yang di sini mungkin ada komen atau pertanyaan atau hal yang relate mau disampaikan terlebih dahulu dalam bahasa Indonesia juga tidak mengapa. Belum? Okay. So I will really a bit trigger about, so going back to what Dr. Handoyo have already shared, that was one of very complex cases that we have ever dealt and discussed together with the clinician at the hospital. So I think I personally try to perceive that context that maybe some of our clinicians that were involved during that case.
In this case,
in the conjoint twin cases, the member of the physician might now, maybe some or maybe all, maybe have such questions, such as Dr. Handoyo mentioned. So I think would that be also considered as moral distress or moral, like a guilt? Because now the question now shift whether we made the right decision considering the situation now, that's first. And then the second, maybe from what I remember during the discussion back then, one of the questions that really is difficult to answer was then until what extent do we as healthcare professionals or the hospital then should take responsibility of the decision that we made that time? Because then we see that like the consequences of the decision that time now is directly implicate, the direct implication is on both the kids or the children now that has already grown when we decided that we keep them tied together, then now they have to live in such way. And so up to what extent then do we have professionals who made the decision have a duty to care because their life now is because of what we decide. So I think those are the basic questions, the nuances now. But then going back to your lecture, how clinical ethics support, or do you have any illustration of the kind of support that can be provided? So then for our clinicians who have been in such situation, after they are able to come to a decision, but then there's doubts or questions, regrets that are coming up after that as an implication. So how does it usually be handled or managed? Because then
for example, in Amsterdam or
maybe in Amsterdam, or maybe if in this case, if you have any suggestion or ideas how this can be managed or dealt with.
Yeah. Yeah, thank you for the it depends a little bit, of course, about the specific moral question of the doctors now with respect to this case. But for example, if this is the timeline, let's see. This one is maybe better. So here's see the time 0 where there was this clinical conference about the whether or not to how you say to separate, yeah, separate or not. At that time, maybe, of course, I don't know the facts, so I know only a little bit. But at that time, this was the central moral question, perhaps. Separate or not. Then you had different meetings, the expert from another country, and maybe scientific papers, whatever. And then now we are here, one, with some of the team members. I'm not sure how many, but some of the team members, they have a new, what would be the new moral question? Did we do the right thing?
Yeah, did we do the right thing? Like, because now they live in the situation unlike the other, so.
Did we do the right thing? Or maybe another question, what is our responsibility now? Or
Yes.
because I understood that the twins, they stayed a long time in the hospital.
Yes. So.
And the hospital had to pay this.
Yeah, the hospital is trying to take care of the patient, both the children, as best as we can, and then also prepare for the discharge. So there's this like long-term plan for helping them to go back to the family.
Yeah.
But then after they are actually be in the society and be with their family, then the question would be, does the hospital or us as the healthcare professionals, do we still, until what extent do we have to be responsible? Like, do we have a duty?
Yeah.
Now?
So which responsibility, this is not good English, which responsibility of hospital, and even the practical question, for how long or in which way? For how long? So I would, if now the team came to me with this kind of question, then first of all, if there is still stress about the decision at that time in the team, for some of the members in the team, maybe not for everyone, then of course you can have a case, then you can have a case discussion together in a specific structured way. You know the way I will tell about it, moral case creation, and you can still ask the question about this time, at that time, with the knowledge we had at that time. Because that's important, I think, logically. You can blame yourself later, maybe for the consequence of decision here. But if you were not aware of the consequences, then you maybe should not blame yourself here. That's more. I don't know if this psychologically helps to the doctor, but so if you now are in doubt about the decision you did in the past, then the question is, were you aware? Or did you acknowledge at that time the moral doubt you have now? So usually it's well, that's maybe a response or.
Yes. Mungkin sambil membantu meng-highlight, karena mungkin kalau sekarang muncul pertanyaan apakah situasi yang sekarang ini sebenarnya hasil keputusan yang baik gitu. Jadi mempertanyakan apakah benar ya kemarin kita buat keputusan seperti itu. Jadi pertanyaan pertamanya mungkin adalah apakah kita dengan pengetahuan yang dulu pada saat memutuskan itu, apakah kita juga punya keraguan seperti sekarang gitu? Karena kan mungkin kita dulu memutuskan dengan informasi dan kemampuan kita yang ada pada saat itu. Sehingga kalau sekarang kita dapat informasi baru, misalnya ada perkembangan teknologi baru kah yang kemudian membuat kita bertanya, oh ternyata bisa seperti itu, tapi itu kan sekarang. Nah pada saat dulu apakah kita sudah punya informasi itu? Sehingga untuk pertama tadi mengadres, so I think your first question would be to address the guilt, right? If you feel guilty now, do you have the information that you have now back then when you make the decision? So if not, then you should not feel guilty.
Yeah,
right.
That's of course a simple answer, and it's easy for me to say here. But if you ask me what should you do, then I think it's good to have at this moment, 8 years later. So this is 8 years. Further, that so if a team or one individual has guilt about the past as a professional, it's important to pay attention to that, because many cases with guilt can burden the professional. You cannot prevent all feelings of guilt, But if it's a serious guilt, then me as doctor, if I feel I really suffer from my guilt and it bothers me almost every day or every week, then I think maybe it's good to have a team discussion about how everybody in the team, about why he or she is in doubt, what kind of doubt, and just talk about it. You don't have to solve it, but talk about it. But if it's a more prospective question, so now and in the future, what is the responsibility of the doctor or of the hospital now? Then you have a case discussion about the facts that you have here, and then you can talk with maybe with the I guess not only with the healthcare team, but also maybe with the director of the hospital. What is a good timing for discharge? That's also a moral question. But so when do we discharge this twin too early, or when do we discharge this twin too late? So that could be, but it's always important in clinical ethics. So where are we talking about in the line of this, the timeline of this case, and is your doubt at this moment and about the future? And do you question have here, or is it what we did in the past? And usually, what I know from literature, that's also about, it's called moral distress debriefing. It's developed by an American nurse, especially a nurse. She found in research that people with healthcare professionals with guilt, if they reflect about the case from earlier, that they feel more relief or understanding or peace with their decision. Not always, of course. It doesn't solve all problems. Is it
Yeah, so the strategy or the methods to moral debrief or to distress, that is so important, right? I mean, that would be the suggested one of the methods to deal with the guilt or the doubt after the decision is made.
Yeah.
But then for the more prospective question, like whether the hospital or us as a healthcare professional team now need to be responsible or need to do more for this patient after the decision, then so we need to do like a meeting or a discussion solving that with the facts now, with the situation.
No, but yeah. And of course, let me, I maybe a little bit meta, what I'm doing now, what we are doing now, is this is about deliberations. Deliberation. And not, this is also important. The way I answered your question is about moral cases. What you also could do is forget about this, and you say, well, maybe we don't have moral questions, but it's more a psychological question. How do I deal with my guilt? So then in Amsterdam, it's one of my slides, by the way, we have also a kind of psychological counseling. So this is very important. Is the worry or the burden of this doctor or some of the doctors or some of the nurses, is it related to a moral question? Did I do the right thing? Well, that is typically morally, isn't it? That's something else than how can I deal with my guilt or fear psychologically? That's enough. So you also go to some counseling, psychological counseling. You can also, in research, we know that if there are guidelines, or if you develop guidelines, maybe in this situation, there was not a guideline, of course, how to solve this. But sometimes we learn from research that if health professionals feel there is a guideline about what to do in a dilemma, in a moral situation, and evidence-based guideline, this can also relieve somehow the guilt feelings. So I'm not saying you should always have a dialogue or a case discussion. Sometimes you can go to psychology or social counseling or the pastoral care. In our hospital, we have, is it pastoral care here? Or religious care? I don't know how to call it, pastoral care.
Yes.
So no matter what kind of religion, we have care from the religion experts, pastoral care. So I should write that down as well. So there are different ways. This is 2, 3, 4, and this is 1. 4 ways how you can address certain stress situations.
So can we say that the moral case deliberation and the psychological support or counseling and then the guideline pastoral care, are those all type that we can say it's different forms of clinical ethics support, or just the moral case deliberation?
I would say that well, sometimes you have ethics guidelines, but I think this is not ethics support. And pastoral care can be ethics support, but sometimes it's more religious support,
okay,
or existential support.
So,
okay.
So here in this example that you have suggested some of the way to approach the situation,
Yeah.
which we can identify as form of the ethics support that can be provided in the hospital is to have this moral case deliberation is one, and then the second one is to maybe developing or have a guideline or reference of policy, so then it helps.
It can also help.
Yeah.
For some people, it doesn't help, but guidance can help also in their stress. If the stress is the problem or the guilt, yeah.
Okay, thank you.
Thank you.
Apakah ada yang mau menambahkan atau sedikit mengomentari atau ada yang relevan? Jadi dengan contoh yang tadi, dengan contoh salah satu kasus yang mungkin cukup kompleks, tapi misalnya kita menganggap ada sebuah keraguan atau ada sebuah hal yang pertanyaan moral yang kemudian muncul, apakah kemarin putusan yang sudah dibuat itu adalah suatu hal yang baik dengan saat ini implikasinya. Jadi hal semacam itu yang mungkin bisa diidentifikasi sebagai adanya mungkin moral distress atau perasaan bersalah, yang itu secara faktual sebetulnya sangat bisa mempengaruhi performa dari tenaga kesehatan gitu, karena bisa saja mungkin itu terbawa atau mempengaruhi keputusannya di situasi atau kasus yang lain, sehingga kalau tidak diadres itu tadi yang disampaikan bisa menjadi long term problem yang akhirnya menjadi burnout gitu. Dan mungkin kalau disadari mungkin itu lebih baik, tapi kalau tidak disadari itu kan yang kemudian bisa menimbulkan serial atau insiden-insiden yang mungkin sebetulnya akarnya sebetulnya dari moral distress atau moral burnout-nya dari healthcare professionals. Maka tadi dari beberapa hal yang disampaikan oleh Prof. Bert yang bisa kita lihat bahwa bentuk moral support atau clinical ethics support yang bisa disediakan di rumah sakit atau di pelayanan kesehatan untuk tenaga kesehatannya itu adalah salah satunya kalau di Belanda, di Amsterdam itu mereka sering melakukan moral case deliberation. Jadi ada sesi sama fasilitator untuk kemudian membicarakan, jadi berdialog tentang apa yang dirasa menjadi permasalahan atau ada pertanyaan konflik moralnya. Kemudian di sisi lain misalnya kalau itu kemudian sesuatu yang memang fundamental atau memang harus ada guideline-nya, maka fungsi mungkin komite etik rumah sakit atau dari rumah sakit itu sendiri mungkin perlu membuat sebuah panduan gitu supaya kemudian memudahkan atau memberikan gambaran arah gitu untuk kasus-kasus yang prospektif selanjutnya, sehingga healthcare professional tidak terlalu kemudian harus bergantung pada individual atau case by case gitu ya. Jadi kalau ada guideline biasanya kan mempermudah. Kurang lebihnya highlight-nya dari pertanyaan contoh kasus tadi seperti itu. Jadi bentuk moral support atau legal ethics support yang bisa dilakukan seperti itu. Ini Bapak dan Ibu ada komentar dulu atau tanggapan dari pengalaman pribadi? Iya, silakan. Dalam bahasa Indonesia juga tidak apa-apa nanti. So I was just re-emphasizing what we just mentioned, and now we have more question. Yeah. Yang mana
Yeah.
Okay, thank you for the opportunity, Professor. My name is Zaki. I would like to tell about my little experience about my experience when I'm internship in one of the rural region, countryside region in East Indonesia.
In which
in East Indonesia.
Yeah,
Nusa Tenggara.
Secondara?
Nusa Tenggara.
Oh, yeah,
it's eastern part of Indonesia.
Eastern part of
but the context was a hospital?
In hospital and primary care, but
primary care, yeah, okay.
But maybe in the hospital. So in the hospital, I found that yes, I'm sorry for the some population in the region is, we can say, extremely poor financially.
Yeah.
So even we have the medical coverage, national medical coverage, which they can go to the hospital and take the treatment freely, but they still have some of the dilemma, like they can routinely go to hospital to, maybe if you take this medication, the next month come here again to re-evaluate the treatment, and then we choose whether we can continue the treatment or maybe we can stop, and that's okay because your condition has been good or not. Nah, in this region with the poor people, I found that they can go to the hospital because they can afford the payment about the transportation. This is the dilemma is some think that whether we donate some our money to them or not, because they don't have money, they can go to the hospital because the transportation is, they can afford the price.
Do you mean that, thank you for your question. So do you mean that some doctors or healthcare professionals, they have the dilemma or the moral question, should I spend my own money from my salary
Yes.
to let the patient come to the hospital?
Yes.
To pay the transport?
Yes.
Yeah, that's a very sad, of course, example, and it's a very nice moral question of the doctor or healthcare professional. And is your question how you can do with such questions?
Paling galaunya, yang paling galaunya dari mau yang membuat berat atau menghambat mungkin untuk memberikan uang kepada pasien adalah apakah misalnya besok kalau pasien yang dikasih yang lain lagi berarti harus saya kasih dong, atau sampai kapan saya harus begini gitu ya, atau gimana? Galaunya di situ.
So there is some example again from the years before. There are the patients and the doctors decide to spend their money for the patient. Maybe like domino effect. In the next time, not the patient, but some of his friends come to the hospital and say, I know this doctor who we will spend money for my treatment and my transport, like that.
Yeah. And then so first is the question, shall I spend my own money as a doctor for the patient? And then the second moral question will become, if I do it with this patient, do I also have to do it with that patient? And that patient and that patient. Yeah. Yeah. But that's, I think, of course, this is a personal moral question for this doctor. But, I don't know the Indonesian context, of course, very well. I would also say, as hospital, I would, or as management of the hospital, I think you should be try to help the doctors also that they cannot rescue the world. So it's a little bit, so I think it's, this is a personal, maybe a struggle for the doctor. Should I pay this single patient? But it's also important that the hospital or the association doctors in Indonesia, I don't know, maybe there are guidelines for this, that they also give some support that there is a limit to what you can offer others to help. Yeah, so this is a very nice example. I also heard about an example from Tanzania. I am supervising a PhD student in Tanzania, Africa. In Africa, they want to buy ethics support as well, or in Africa, but in Tanzania. And he said, Bert, many healthcare professionals here, although we can treat the patient in the hospital, so then the patient is already in the hospital, or we can treat the patient, most of the patients and the family of the patient have to pay for the treatment themselves. And then because the family is very poor, the doctors, they say to the family, we cannot cure you. It's better that you go home and take some herbal medicine. So that's also a moral. So even the doctor knows it's possible to help, but the doctor doesn't want to increase the financial burden of the family. So then he, as a doctor, he's saying, or she's saying to the patient, we cannot treat this now. It's better that you go home, knowing that then he or she will die. Although in the treatment, in the hospital, he or she will possibly survive. That's also a very sad example and a moral dilemma. But thank you for your, I'm not sure whether of course I did not answer the question, but I hope my reaction helped a little bit. So we continue with the presentation, or do you have an additional question?
I think that's enough.
Oke.
Really?
Yeah,
Okay.
that's enough.
Yeah.
Oke,
Yeah, we
terima
could,
kasih.
such cases like here are heavy case. We could talk about it for an hour, longer. So I'm sorry, but we have another 20 minutes. That's right,
Yes.
isn't it?
Yes,
Yeah.
we have another 20 minutes.
So now I learned the words. What was the word? If you say, come on, can you continue?
Semangat.
Who?
Semangat.
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 Yes.
Okay, semangat. 20 minutes.
20 minutes.
20 minutes. Keep fresh. In Scandinavia, really, I work in Amsterdam and in Oslo, in Norway. In Scandinavia, they have these long sessions, well, long, 2 hours. They say, okay, let's stand up
Oh, yes.
and
Stretch.
stretch a little bit, and then salam,
Semangat.
samangat,
Yes.
samangat,
Semangat.
samangat. Okay, there we go. I will be a little bit more quick now, but so we talked about different ways of doing ethics in the hospital with different kinds of ethics committees, with moral case variations, guidelines. Now this is from research from my colleagues from Switzerland and Norway. Here you can see different things. This would be fun. I would like, and I'm talking at you, I would talk to your ethics committees in your hospitals. I would like to visit them and then ask them, in the ethics committee, what are you doing? Because these are different ways of what ethics support staff, there's also committee members, what can do. And this is very friendly and open. And here the ethicist is only listening and talking, trying to understand. Here is clarification, that's a little bit more interpretation. Here it's interpretation clearly, even evaluation, analyzing argument, pro and cons. This is referring to or rely on norms. And you see, it's more and more becoming more the expert role. And here, the ethicist or the ethics committee, whatever you are interested in, they say, well, we advocate for treatment A, or we advocate for treatment B as ethics committee. Or if you have the ethics committee, maybe with the misconduct, then you are on the 10th level, being quite normative. This is not allowed, this behavior is not allowed in this hospital. This is wrong. So this is here. So it would be fun for empirical research in the hospitals in Yogyakarta, in the committees, I mean. First, what do they think their tasks is, or what do they do? And also, we could ask the healthcare professionals, what do you need from the ethicist or the ethics committee? So I like this scheme. I think it's clear. Okay. Now a little bit overview of what is ethics support. Now I go a little bit back to what more broader. And I hope to also show some results of the evidence of why it's good to pay attention to ethics. Some of you maybe already know, but like Rashid also say, there are health ethics committees. I'm not talking about today about research ethics. So I'm not talking about ethics committees that approve or judge research. So this is clinical research, clinical ethics. So usually in the literature, internationally, they say, well, ethics support consists of ethics committees sometimes. Sometimes you have ethics consultants, especially in America, in the States. Sometimes you have moral case variation, that's more from the Netherlands and Scandinavia. So a lot of dialogue here. Sometimes we do ethics rounds, like we talked on before this morning. And sometimes we have moral counseling. Moral counseling is talking with patients and families about their moral concern. So 5 ways of doing ethics support, clinical ethics support. And of course, you can do ethics in many different ways. I'm a little bit afraid that people think only if I go to the ethics committee, then I do ethics. Because if I wash a patient, I'm also doing ethics. What is good washing and what is good? So it's not, that's a little bit my message here. I'm not sure about, Rasid, you talked about accreditation. So do hospitals in Indonesia need accreditation audits, whether they are a high quality hospital? Is that kind of accreditation? Yeah. Okay, that's enough. Maybe that's yeah. Okay, just check, because in the Netherlands, I'm not sure whether this is here in Indonesia. In the Netherlands, we also have accreditation. But the funny thing is, and I like this as an essence, in the Netherlands they have accreditation, and then and the hospital always wants to have the accreditation, of course. But in the Netherlands, more and more accreditation is writing, you as a hospital should have a structure for ethics support. It's required from the accreditation companies in the Netherlands that hospitals take care, have a kind of ethics support like this. One of them. So I call them partners in crime, because therefore the hospitals and the management of the hospitals, because they need the accreditation of the hospitals, then if the accreditation organization says you should also offer ethics to your healthcare professionals, it's a extra support for ethics support. Okay, something background information. Now the local situation in Amsterdam. So I work in 2 large academic hospitals, 2 medical faculties, and we are now merging together in 1 hospital. So here it's Free University Medical Center, but nowadays, next year in January, we will be Amsterdam University Medical Centers, 2 large hospitals, 17,000 employees. So really large. And in the Netherlands, it's the largest hospital. We are lucky in Amsterdam. We are lucky because we have quite some money to do ethics support, and that's so this is quite luxury. In the most hospitals in the Netherlands don't have that much, but because I am the chair of ethics support, because the board of the hospital, they pay 100,000 euro every year, 100,000 euro every year for ethics support. I know this in Indonesia sounds a lot, but to translate it to maybe the Indonesian context, 100,000 euro every year I get from the directors to offer support for healthcare professionals. And this means in practice that I can pay in my team 1.5 ethicists, 1 full-time ethicist and 1 half-time ethicist. So with 100,000 euro, that's, I guess you can pay more ethicists here in Indonesia, but I can pay 1.5 ethicists the whole year to do ethics work for healthcare professionals. This is, of course, yeah, fantastic. So we have 1 ethics committee. We have about 50 facilitators that do the case discussions, like the cases we had. 50. What is important, we facilitate from the Department of Ethics, from my team, we go to the hospital and we facilitate the case discussions. But I think the ethics is not from the ethics department. So what we try to do is we try to train nurses, doctors, people like you. We try to train them to be a facilitator in case deliberation. So in the Netherlands, you don't have to be an ethicist in order to work in ethics support. So people from nursing, psychology, or the wards, physical therapists as well, they are trained as facilitators. We have moral counseling for patients from the religious pastoral care. We have consultation, not that much. So sometimes they call us and they want expert advice from us about ethics topic. We have ethics education like you, like today here. So that we have lectures. We also use moral case relations as a method to discuss cases in the teaching of medical students and nurses. So that's using ethics support in education. And we have all kinds of projects. I will talk about that later. This is a Dutch slide, so maybe we can try to learn some Dutch. And some of the Dutch is related to Indonesia, of course. But this is a Dutch slide to explain to you that all the ethics activities we do in the hospital in Amsterdam is not only at the ethics department, because ethics should not be from the ethicist. That's although I'm an ethicist. So what we do in the Netherlands, here you see our department, the Department of Ethics Support. Here you see my chair, the Professor Chair of Ethics Support. Here's the committee, the Ethics Committee with doctors, nurses, managers, human resource management, quality management. So they work with ethics support, pastoral care. Go to the other side. Here we have it's Dutch, but it's the working group on quality of care in the hospital with quality of care management. This is the helpline, the telephone line. If people have moral stress, they can call us. This is the board of directors, and these are the 50 facilitators for case discussions. So what you learn here is that if you ask us what kind of ethics support do you do in Amsterdam, well, there are many ways many people are involved. Here you can see many kinds of ethics support. So I hope this is informative for you. But here you see that we do the ethics support together, not only the ethicist. So in the middle, all they come together here, and that's called the klankbord group or the advisory group. So my job in the hospital, I'm an ethicist and a professor in research and teaching, but I spent 1 day or a half day every week, 1 day or a half day every week. I spend time as a professor in ethics to talk with the management, to talk with the quality management, to talk with human resource management. Because I think, and therefore I think we can sell ethics so well, ethics is not only something from the ethics department. So I spent a lot of time to build this structure that the advisory group thinks with us about what kind of ethics issues are there? How can we help you, hospital? So it's really support in a way. And I think the problem is that many people only see ethics as something from the ethics department or the center of ethics. It's good to share. Okay. I will skip this and I will tell a little bit about the last part of the last 6 minutes will be about research about the impact of ethics support. So I will skip this story. This story is about in which way do we do the case discussions, the moral case evaluation. You can read it later. You can email me, and there are many papers about moral case evaluation. There are also videos about moral case evaluation.
And we have the session with you tomorrow afternoon.
Yeah.
So
yeah, there is. Oh yeah,
MCD.
Yeah. So this is fun to talk about, but I will skip it now because I want to go to also on fun. Yeah, I have abuse of ethics support. That's also nice. We can talk about that later. This is an example of, I will not tell about, but then you know what you miss. This is an example about, my concern is that we do a lot of ethics support, but we don't take the insights from ethics support to the practice. So we made a lot of ethics support tool in Amsterdam, ethics support tools, in which we collected all the information from ethics support to a tool for healthcare professionals. So they don't need the ethics committee anymore. For example, a moral compass, gender journey about shared decision-making, gender care, all published. This is not published. Competence consult, this is a moral questions about decision-making competence. Confidentiality consultant, that's the English term, about confidentiality issues. When am I allowed to tell something about this case to others? So here you see, this is the consult, what's the name? Confidentiality consultant, the blue one. It's almost published. This is, oh, sorry. This is the Dutch confidentiality consultant. And here you see how we, this is also ethics support. Ethics support, this is a kind of interactive guideline. So people in the hospital that have difficulties with confidentiality, moral difficulties, they can use this Dutch guideline and they can learn. Here you see all the menu with all the chapters. And they can, you see different values that are at stake, all based from research in the hospital. And here you can see that it's interactive, so they can write down, doctors can write down which value is more important in this case for you, which, etc. And here you say, what kind of decision-making did you do? What were the arguments? What were the core moral question? So this is a way also of ethics support. Then they don't have to pay to go to the ethics meeting. They don't have to go to the case discussion because it takes a lot of time and healthcare professionals are busy. So I think ethics support tools is very important. But this is my slide, one of my last slides. Maybe you can read it. I really like, I'm a social scientist, I'm an ethicist. I really like this picture. I use it everywhere because I think it's good to reflect upon ethics questions, but in the end, we want and we should, with ethics, we should improve the practice. Therefore, research is important. What is the profit of ethics committees? How do we improve the moral distress from healthcare professionals with moral case variations? So that's important. Here you have an overview with all kinds of, we have been doing research evaluating the impact of ethics support since 20 years or 18 years. So for example, we found out, we have research about what kind of teams were discussed, what was the quality of the process in the ethics support, what was the content. But here, this is important for us today. We also did research, and not only we in Amsterdam, but also people in Scandinavia and the States and Germany, that found that if you do ethics support, it can improve the quality of care, it can improve decision-making, it can improve team cooperation, and it can improve the moral competency or the moral skills of healthcare professionals. So how they deal with the moral issues. And these are just 3 papers, but I think there are 50 papers about this. So this is only the summary. And this one example from this thesis. This is a PhD thesis from one of my PT students 2 years ago, Janine de Snow. And she wrote her thesis, doctoral thesis, about what are the outcomes of MCD. So if you have case discussions in hospital, what then does happen afterwards? What are the outcomes? So this is evidence-based research. And we found, I'm a little bit superficial now because of the time, but we found that moral case deliberations, so ethics cases, they improved the moral reflexivity of the professionals. It develops my skills to analyze ethical difficult situations. It gives me courage to express my ethical standpoint. So it improved the moral attitude. Me and my co-workers manage disagreements more constructively. Remember what I said about dialogue and disagreements. It makes me better to manage the stress. That's also an outcome in this research. It contributes to the development of policies in workplaces. And finally, it contributes also to concrete results. For example, I now know what to do with this patient or with this family. I will skip this, I think, and this is the last slide. So moral case variation is a structured way of a dialogue. It's one way of ethics support. It's not the way, it's only one way. And it's usually done by a trained facilitator for having a dialogue. And then you could see at MCD, moral case variation, as an ethics support. It's a quality instrument which can also be used to develop or adjust policies. It's not only case discussions, you can also use MCD for policy and guidelines or decision aids. So that the ethics tool that I just showed you briefly is a way where you can you use MCD to make an ethics support tool or a moral compass. And finally, empirical evaluation research shows that MCD can contribute to moral competence, self-care, team cooperation, and in the end, I think the most important, it can contribute to a better quality of care. It's exactly 10 o'clock. Thanks a lot for your attention. And you'll be tired after so much talking from my side. I hope it was relevant. Thank you.
Thank you, Prof. Bert. Very much appreciated for sharing such very interesting and detailed and comprehensive information, even though we have very limited time. So I will just help highlight from the beginning. So very sangat-sangat sebetulnya sangat relevan, dan karena approach yang dibawa oleh Prof. Bert dan maksudnya merefleksikan dari apa yang banyak dilakukan di Belanda terutama, bahwa ethics itu dilaksanakan dengan tujuan utama improving practice itu. Jadi bahwa ethics itu bukan sekedar dilakukan secara akademik, apa research-nya, apa hasilnya, atau kemudian secara normatif, tapi memang misinya adalah bagaimana membawa ethics itu ada di praktek keseharian layanan kesehatan dan punya dampak untuk membantu mensupport pelayanan. Dan tentunya ini tembakannya adalah kalau dengan MCD ini bagaimana mensupport atau menguatkan dari tenaga profesional kesehatannya sendiri. Jadi tadi kalau ada beberapa hal yang tadi dilakukan doing ethics itu caranya bagaimana, bisa lewat komite etik, bisa kemudian dengan aktivitas yang lain. Mungkin highlightnya yang saya pribadi melihat berbeda adalah ethics dipakai tidak hanya untuk memecahkan masalah yang ditemui oleh tenaga kesehatan dalam praktek keseharian, jadi tidak hanya untuk membantu mendiskusikan kasus sulit, tapi juga dipakai untuk mengimprove atau capacity building tenaga profesional kesehatan. Jadi untuk self-care itu tadi. Karena dengan self-care, dengan reflection, harapannya adalah in the long term nanti kapasitasnya terbangun dan kemudian terbiasa untuk menavigasi permasalahan moral atau dilema yang dihadapi kesehariannya. Jadi ada goal long termnya yang kemudian bisa improving practice. Jadi itulah salah satu yang mungkin kami Center for Bioethics bisa berdiskusi dan bisa berkolaborasi dengan AMC, dengan Prof. Bert dan nanti dengan kolega di masa mendatang. Salah satunya adalah untuk misi yang sama, bahwa ethics itu akan bisa sangat bermanfaat dan praktikal, dan nanti memang kita cari ya bagaimana tidak kemudian apa yang ada di Belanda langsung kita bawa ke sini, tapi sebagai gambaran bahwa ada cara atau sangat memungkinkan ethics itu bisa dipraktekkan dan embedded atau attached dengan keseharian prakteknya. Jadi mungkin itu highlight utama dari kuliah umum, karena memang sifatnya kuliah umum, jadi mungkin lebih ke icip-icip atau tidak terlalu mendalam, tapi secara broad gitu, bagaimana mengadvokasi kepentingan clinical ethics support pentingnya untuk sebuah layanan kesehatan. Jadi ini dipandang sebagai sebuah kebutuhan, bukan lagi sebuah tambahan atau pelengkap. Dan untuk secara lengkapnya, secara detail, karena tadi memang banyak sekali Prof. Bert berbicara tentang moral case deliberation, itu sebagai salah satu metode yang bisa masuk ke dalam keseharian, yaitu dengan diskusi kasus, dengan fasilitator, dengan debriefing. Cara melakukan MCD itu yang secara khusus akan diajarkan Prof. Bert, akan dicoba dilatihkan, disimulasikan di sini besok. Jadi besok hari Selasa di jam 1 sampai jam 5 di ruang sama di sini. Khusus satu sesi workshop itu untuk mensimulasikan bagaimana sih mendiskusikan kasus dengan metode moral case deliberation. Jadi kita akan punya 2 case presenter dari kita, dari Jogja, jadi dari perwakilan klinisi kita, dan nanti Prof. Bert setelah pemaparan umum konsepnya kita akan coba 2 round atau 2 kasus itu khusus untuk moral case deliberation, sehingga semoga nanti memberikan gambaran apa sih yang dilakukan untuk bisa memulai dialog itu ya, bahwa ada permasalahan walaupun kita butuh jawabannya, tapi yang pertama kalau bisa dengan dialog sama-sama belajar mengeksplorasi perbedaan, biasanya kuncinya nanti ada di situ gitu ya, dan itu yang bisa dicoba dipakai dengan moral case deliberation. Mungkin itu secara umum, karena waktunya sudah 5 menit lebih dari jam 4. Tapi kalau misalnya ada burning question, ada hal atau konfirmasi atau klarifikasi sebelum kita tutup, di online ada pertanyaan kah di chat? Tidak ada. Okay. So now, because there's no question from the chat or the online, and the participants here doesn't seem to have more question for now, so I was just inviting, so then everyone can also join our session tomorrow about the MCD simulation, because that will make it more detailed and have illustration
more concrete
about how MCD is conducted. So do you have any conclusion or closing remark for this session today?
Oh yeah, I have my microphone.
I forgot.
Now maybe I think the message would be that I hope that you will be more able to recognize the moral dimension of your work, and that there are ways to deal with the moral dimensions, not only because moral issues are important also for your healthcare, your own well-being, but also because attention for moral cases like this, or moral attention for clinical ethics, can really improve the team cooperation and the quality of care. I think ethics support is really a quality instrument. So it's not only because you think, oh, that's interesting to do philosophy, really about concrete things on case level and policy level.
Yeah. Thank you, Prof. Bert, for the very nice and solid conclusion. And we hope, yeah, we're recording it, so we're going to maybe sometimes cut on the last one. So that's the highlight. So that's what we are going to advocate, how it is important for healthcare. Thank you, Prof. Bert. Mohon apresiasinya sekali lagi Bapak dan Ibu, dan sekaligus terima kasih juga atas partisipasi dan diskusinya. Kami sangat bahagia kita bisa berbagi beberapa kasus, bisa ikut mendiskusikan bersama Bapak dan Ibu. Mohon maaf apabila ada kekurangan, dan sampai jumpa besok. Jadi untuk Bioethics Week kita masih punya satu rangkaian acara lagi besok. Pagi hari workshop kita lanjutkan dengan empirical research ethics. Jadi Bapak dan Ibu misalnya tadi tidak ikut yang research hari ini, besok bisa ikut nyambung karena kita akan lebih fokus sharing apa ide-ide penelitian atau pertanyaan penelitian yang bisa diberi masukan oleh Prof. Bert. Dan untuk siang harinya seperti tadi highlight jam 1 sampai jam 5 kita akan di ruangan ini mensimulasikan moral case deliberation bersama teman-teman kita para praktisi klinisi dan juga panel anggotanya dipimpin langsung oleh Prof. Bert. Demikian dari kami, terima kasih banyak atas partisipasi dan dukungannya. Sampai jumpa besok. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you. Thank you. Thank you.
Terima kasih juga bagi Bapak dan Ibu yang ada di online. Jadi, sampai jumpa besok kalau bisa bergabung online di waktu dan link yang sama mungkin.